If we are training only technique, you'll end up with something like this. No understanding why we do what we do, and we end up with this failure. This is a 22-year-old young female. And if you look closely, you can see the implant showing to the bone with very thin biotype. So, or this case where it started with a little bit of inflammation on the mesial, they didn't pay attention until 4 years later, and by the time they referred her to me, she was like this, purulence, edema, and then by the time we opened the flap, it was gone. That's the case that I showed at the webinar for Dental XP. Or this wonderful lady that came with sublingual inflammation, and when I look at her scan, you can see it's a perforation into the floor. Now, when I communicated with her dentist and I asked her, can you send me her x-rays for the last visit? And sure enough, she sends me in January of 2013. And if you look at those pictures, you can see that the bone loss started from then, and it led to where we are at that point. So, placement like this, or my favorite is this one. And I don't need to say anything about it. So, the puzzle. That's the puzzle that Buser and then complication. The second one, survival, is no recorded one, and complication is only prosthetic. Well, if you look at the survival rate at 5 to 10 years, it goes from 90% to 81%. But this is considered survival. Survival. That's not success. Or this case, 10 years later, when you look at the x-ray, a lot of bone loss, no inflammation, but this is considered also survival. But is this correct? The fun part, again, is the population of the world is going to increase 36%. I don't know if you love statistics, but I love statistics. And if you look at the statistics, you can see that most of them are going to be in the third bracket of age. That means the people who are treated now, they're going to live longer, or the people who are going to live longer, they will require more implants. So the demand is going to increase, and the challenge is going to increase. So what have we learned over these years? One is aesthetics, and we can't pick a better model than Julia Moore. So if you look at her smile, and everybody relates to her, but in reality, she's a nightmare for every dentist. So if you make a mistake with her, you end up with teeth like my children Halloween. And she's here, actually. And, or in reality, for us in surgery, you need to look at the parameter that makes us work or fail. And the parameters are, if you put them together, the buccal corridor, the gingival margin, smile line, and the symmetry that Steve Chu has talked about. Because if you get a patient like this, and you put everything together, any failure with this patient, either mandibular or maxilla, it will reveal itself. So you can see a case like this who has been treated by 2 prominent surgeons in New York. When they extracted that tooth, the site preservation led to this. In order for us to fix that, it's going to require a lot of soft and hard tissue. So how can we prevent that from the beginning? So a lot of people talk about a lot of classifications and roadmaps and all of the good stuff, but in reality, we came up with a new one, because look at this case. If we take this patient and we want to extract her tooth, is it enough just to put a bone and membrane, or we have to look at a bigger picture? Well, we came up with this roadmap, and in this roadmap, I'm not going to dwell too much on it, but this part will relate to that case. So how can we manage it is by extracting bone and relying to soft tissue. That is the rotation of a connective tissue from the palate. And actually, this is a modification of the original technique. And you can see where we go from here, and we can end up with a result like that. Just by understanding the roadmap, because our roadmap doesn't only talk about the walls of the socket, it talks about the proximal bone, apical topography, and the soft tissue nature. So this is an article that has been accepted for publication in the International Journal of Perio and Restorative Dentistry about the modification of that technique. Wound healing. The wound healing starts with the bone. And when we look at the bone, and yesterday Buser had talked enough about the space creation, and that's the original study. And space creation, maintenance of that to the blood clot, and will lead to a trabecular and healthy bone. But one has to go back to that study that Schenk and Buser group has done, and you can see how when they created the space, the bone came from the walls. And the walls are the dictating factor in that matter. If you look at the histology on the right, you can see how much the bone is immature in 2 months. And later on, in 4 months, you can see it started to trabeculate, but it's not there yet. That's how we all learned about the 6 months period. And if you lose that space, everything will collapse. Those principles will never change. How about sockets? Well, sockets, same thing. It has to go through the same process from the blood clot to the trabecular bone. And if you look at the most beautiful study that Kardarapoli has done, everybody focus on one part of it, but in reality, there is one picture that is the most important thing, is the walls. And these walls are full of canals that brings out all of the good stuff that create that blood clot and produce the bone that we need. So when we talk about socket, we need to learn about the walls, not just the bone and the membrane. The vascularization, because the vessels are important and everybody talked about it throughout the day. And this is a picture of a monkey that we strip him from the soft tissue, and you can see how much the vessels are. Well, if we look closely, this is what we have on a natural tooth. And that's what our colleague before Hatzler was talking about. These are the vessels. This is the PDL, this is the supraperiosteal, and this is the intramarrow. You cut through them, don't wonder why the papilla has gone. So how about the implant? Well, the implant is negative to start with. It has no PDL vessels. And if we put them together, you can see how the component of the peri-implant tissue is totally different. There's no collagen fibers that inserts in it, so the inflammation will grow straight to the bone, and there's no vessels to bring the good stuff, and the soft tissue is scarring. So already we're dealing with a very negative environment. And thirdly is the effect of soft tissue. In 1996, they talked about that. They talked about the thickness of the soft tissue. Nobody believed them. They said they're creating stories. They put a standard abutment and so on and so forth. Even my school criticized them. And until later, Linkovic, which he was part of your panel of last year, he proved it eloquently that if you have less than 2 millimeters, you will lose 1.45 millimeters of crestal bone. And again, the importance of the biotype in 2015. The materials. And again, we've heard all day long about autogenous bone and bio-os and allograft and all of this stuff. But when I was training, it was easy. We had one bone, one membrane, and one implant. And that's it. Today, you need to have a PhD to understand what's going on. Well, allograft has moved. We don't need any more autogenous bone. We don't need any more xenografts. And if you look at the study done at NYU 2006, they proved it. Using cancellous bone, twice the bone, vital bone, than the xeno. And not only that, only quarter of residual bone is left of the graft. Again, I proved it in the case series of histology of sockets using the DBM. And just now, this month, we had a publication about the ceramics. And you can see the difference between having an allograft compared to a synthetic or a xeno. And if you look at the trauma, they have actually looked at the different component of that mineral bone. The one that is cancellous versus the cortical and the combination of both. And they've seen and have noticed that the cortical bone will reduce the resorption. So if you combine the two together, you have a better world. And if you can see, this is a new study by Nevins of last year and talked about, again, combining cancellous and cortical together. The percentage is the one that is still in the game, but you have to have the two, and that is the best thing that we have with allografts. And crestal bone loss, and I would like you to be a little bit open, even if it's Saturday afternoon, because this is the most important thing. What will dictate the loss of bone crestally? Can we solve it just by bioengineering? And that is where the whole thing sits. So if we take this young man that presented, and we had the bone, and the gentleman that referred them to me wanted a certain particular implant with platform switch and micro threads. So I did, and I placed that implant. Everything went fine and went for restoration. 3 years later, this young man presented with a disability in his legs. So he tried everything. Tall guy, taller than me, healthy. So he went to a holistic dentist. Have you heard about holistic dentist? Yeah. And somehow, don't tell me why, but there's the meridian. And guess where that meridian came from? The implant, the second molar where we put it. So this man wanted to have his implant out at all costs. Negotiated with him back and forth. It's a great implant. My heart is going to go with it. He said no. All right. So I asked the dentist to remove the crown. He did. And look at the x-ray. I took it before I removed it. Beautiful bone proximally. So I opened the flap. And again, look at the soft tissue, healthy and all. Look at the bone proximally. You can see the bone at the edge of the implant. But if you look at the buccal, there's no bone. You see that? So there's no bone on the buccal, but there's bone on the proximal. Yet why? So let me take you another case. This is a beautiful case. Somebody went through orthodontic surgery, did not want to have any bone regeneration. So we went for 2 implants, 3.3, to create 1 molar. And placed the implant, and I think they're very successfully placed. 2 weeks later, boom. 2 weeks later, more bone loss. 2 months, it stabilized. Everything was healthy, restored it 5 years later, he was okay, but why? Why this crestal bone loss took place? Yet I followed everything that the manufacturer and the bioengineering and all the good stuff. Or this case that was done at NYU, and I know the faculty, is a wonderful guy. He was one of my teachers. He placed the implant perfectly. 1 month later, like this. Question becomes why? Yet I can show you a case 19 years later with external hacks, pure titanium, and all of this good stuff, but the bone is growing over that micro gap. Again, why? Well, if we go back to the fundamentals, we always forget. It's everything been written in perio from a long time. Wilderman, 1960, did the wound healing of the flap. Well, if you look at it, the way they did it, they took the buccal plate of the tooth, which is only a vascular bone, cortical over cortical. They stripped it from the soft tissue. So again, what happened? PDL is the only vessel that is there. No more vessels coming from the flap, no more vessels from the intramarrow. So if you put them together like this, and imagine that I don't have that vessel here, what's going to happen? Look at the middle and look at B and C. It resorts. Because the blood is not there, the bone is dead. If you look at Buser in 1995, they continued the study of shank. They let those defects heal. They went and placed implant. 5 out of the 12 lost bone. 5 out of the 12. So if you read what they found into the discussion, because you place an implant with a thin buccal plate, you are depriving the vascularity from the medulla to reach that cortical bone. So if you take those two together, and then we review those cases, and we look at this gentleman, and you look at the original scan, and you put that circle around it, it had only medular. There was no cortical there. So it went kaput. If you look at this case, and you look at the original scan without the implants, and if we put the circles around them, it's a vascular bone over a vascular bone. That's where the neck of that implant is going to sit. And guess what? The bone is going to go. And that's exactly what happened with that case. When we looked at the scan, the original scan, back from it and behind it and forward to it, you can see the same story, either 2 cortical bone or 2 medullary bone. So what did we do for that case? We built up the bone, and that's on the anterior. And once the bone was ready, we moved ahead and we placed 3 implants. And when those implants were ready, we moved again and we removed the posterior ones and we placed 2 more angled ones. And the patient went for final restoration, and she's been in function ever since, and everything went fine because we went to the bone where it was balanced between cortical and medular. And we built enough bone, and we used the different diameters. Or take this case. We have a grant at NYU. We place a lot of these pre-doc implants, they call them, for overdenture. Supposedly, it's no-brainer. You just drill a hole and put an implant, and everything should be happy. Well, let me tell you, when you are on the driving seat and you see the failures, then you ask your question, what's going on? Well, take a look at this. The planning was perfect. They put a stand, they put the implant where it should be, and 3 months later, half of the implant is exposed. So again, what happened? Well, we look again in that scan, and if you look at it and follow Buser, so when you put an implant with a very avascular buccal plate, don't expect a bioengineering platform switch, whatever it is. It's going to not help you. It's going to go. So what did we do in that case? We waited for it to heal, and after it healed, we flattened the ridge, and we placed an implant within a balanced bone. And then we followed what Linkovic has said. We increased the soft tissue at second stage using an alloderm and with tax. And that is a poster that has been presented by our students at the AAP. And this is the healing 1 year later. Again, balancing the bone. Treatment planning. I love that part because you can see other people's mistakes and you wonder what happened and so on and so forth. But if you look at this case, and it's a short implant, it's fractured, external hex. I asked the dentist to send me an x-ray before it happened, and you can see that implant lost crestal bone. Now, again, we can discuss a lot about short and not. It's not about that. Look at the bone and look how corticated it is. So when you place a short implant in a highly avascular bone, don't be surprised that you're going to lose the first 3 threads, if not more. So make your math. So now we remove that implant, and after we remove it, we've built it up, and after we build it up, and we gained height and width, and I placed 2 implants. Instead of 1 implant, I used 2 smaller implants, and we took the molar, we divided it in 2 premolars because the space is big, and this is 5 years follow-up. Again, we balanced the bone, we kept enough thickness with balanced cortical and medular with it. Or take this case. Again, implants close to each other, led to peri-implantitis, smoker, the whole thing failed, and I removed them all. And then at that point, after it healed, we flattened the ridge, and we can see the amount of medular bone with the cortical bone. You can see the purple, the pink in between. And now you place your 4 implants all on 4 or whatever you want to do it. And this is the case finished, and that is a follow-up of 3 years. So again, we can reverse things if we follow the biology. Or this patient. This is a 36-year-old young man presented to my office, complete destruction. Again, when you look again about it and you say, what happened here? Well, they didn't follow the protocol of immediate implant. It's not the immediate implant that is going to lead to the failures. It's if you have an apical topography, if you have a good grab of the implant in the primary stability, you have enough buccal plate, and so on and so forth. That's why the socket management that we have promoted right now, it is so important because it's multifactorial. It's not only take a tooth and put an implant or just put bone. So to make story short, this is how he presents. 36, looks like a 70-year-old, completely edentulous. So I kept number 14. I removed the others. We planned for mini implant to stabilize that denture that he has right now. And when this was done, then we moved on and we did sinus lift on both sides. And when those healed, we went and replaced the first round of implants. Again, we used some expanders, and if we have enough thickness, we didn't build the bone. But if we didn't have enough thickness, we built the bone as we did on the left side. Now we have the denture held by mini implants. This way, it does not impede on the healing of the bone graft. And we waited enough, and now we removed number 14 and we replaced it with a good implant. And then when this was ready and transferred, now at that point we added 2 implants anteriorly, and then we moved this gentleman, who is now at that point 42, to 8 implants and more support for a long term. Or this case, that is another favorite that I have. This is 8 implants on the mandibular, multiple surgery on the maxilla. The guy actually lives in Florida. I don't know why he comes from New York for treatment. But nevertheless, when you look at him, he's walking like this. He's traumatized. He doesn't want to hear about surgery anymore. When you look at the scans, you can see the bone graft, iliac grafts have been done on him. I call them the graft to nowhere. Remember that bridge to nowhere? Same thing, graft to nowhere. They put graft, iliac graft, on the lateral window of the sinus. So even that I can't use. The guy does not want to hear about surgery anymore. These are real stories. This is not, beautiful stories or beautiful cases like before, beautiful ceramics and all. This is real life. And trust me, when you're running a program as big as NYU with multi-operational, multi-patients, you see a lot of these things, and you spend a lot of time apologizing, holding hands, crying. It depresses you. Something that should be good should always be good, but has to be built on good foundation. So this case, we found 5 spots. We used guided surgery. We placed the first round of implants. And when we placed them, we wanted to make sure that they are reinforced enough that they will never fail again. And here on the one in position number 8, we built that foramen, incisive foramen, by removing it and building up bone. And this is something has been done at NYU many, many times. And then we let the maxilla heal. He's still walking without denture at that point. He refuses. And now I went to attack the mandible. By the time I was removing the bridge, the middle one came out. When I opened, you can see there was no buccal plate completely, and the lingual was going all the way down, we say it in New York, to Chinatown, while to genial tubules. It's very aggressive at that point. So build it with titanium mesh. We kept some of the implants to hold the temporary, and then we waited. Then later on, we removed it. And now when you deal with titanium mesh, you will see the soft tissue is an issue. So we have to reinforce that. I added 2 angled abutment implants on both sides, and we will remove that implant that is sticking out. And we did the alloderm just to increase the soft tissue in that site. And that's how he presented after that. So now he wanted a break. He is completely held by the top and bottom. He needs on the right side another sinus lift with an implant. But it took a course of 3 years to get him to that level. So he wanted a break, and understandably so. But this is what you deal with when you are dealing with failures and complications. It's like people are unhappy and tired. But complications are not only for implants. And I love the presentation before by Dr. Zadi, my colleague from California. And it is so eloquent the way he did, but that case cannot be done so eloquently and nicely the way he did it, because this is a totally different scenario. This is a canine exposure that went south. I don't know why also we say we went south. Poor Florida. But in reality, it went wrong. Why? Because we do a seminar at NYU between orthoperio. I always tell them, you are the landlord of the soft tissue. They look at me, what do you mean by that? We do the exposure for you, but after that, it's your problem. If you don't follow it and you see if you're bringing soft tissue with it or not, don't come and cry for me. You are the landlord. You are the owner of your case. And they need to learn how to read the soft tissue. So look at this case, and they wanted to fix it. And you can see that eminence of that root. Now, we remove that class 5. We open the flap, and when you open the flap, you can see the discrepancy between that eminence and the recipient bone. Now, anybody who does soft tissue will know that if you put a soft tissue with an open gap underneath, it's impossible for the 4 days to get these osmotic fluids to keep that graft from collapsing. Impossible. So the way that I do it, and it's been very successful in multiple cases, is we put cancellous allograft, and you can see the cancellous, it does not dry the bone, the blood, and look at it how it turns red. We put the soft tissue above it, we stabilize it, we stretch the flap down to get in coronally advanced and cover it. And this is the result. And that is a follow-up of 3 years. But that's not one case. I've done over 30 of these same techniques, and we submit them for publication in Journal of Cosmetic Dentistry. Again, same principle after a big eminent roots with grooves in between. And lastly, my favorite topic is the periimplantitis. That's that was the beginning of my journey, and it's like my curse, never go away. For some reason, I end up doing a lot of periimplantitis. Well, periimplantitis, it's a very touchy subject because everybody tells you, my way, I know how to deal with it, this is my potion, I take it out of my pocket and I do it. But what's real and what's wrong? And that's where I want you to really open your mind on it, because it's so much talk. I give a 3 hours presentation on periimplantitis. I'm going to do the same for some reason every year at the symposium of Zimmer Biomed at NYU. But let's start by the definition. It's an inflammation of the supporting bone as well as the soft tissue. Supporting bone and the soft tissue. Now, I'm not going to open a subject that is very touchy, which is the probing around an implant, but let me leave it at that. But let's talk about prevalence. So our students usually go to present with BU and UPenn, and when the subject of periimplantitis comes and talk about prevalence, everybody starts shouting in the room, no, that's not true, that's not true. It is prevalent. It is prevalent because we're not looking closely, but it happens, and it's going to happen. It's going to only increase. The most difficult part of periimplantitis is diagnosing it. You have to think differently around an implant. So it's reading the soft tissue is an essence. So if you look at the soft tissue, that soft tissue is dead. It's scarry. Users said it in 1992. Again, they repeated it in 1999. When we talk about scarry, that means it's avascular. When you have an injury, bacteria comes in, the host response, we love to use those terms in periodontics, is negative, is dead. So there's not enough blood supply to come. So when that inflammation or that foreign body comes in, it goes straight down to the bone. And if you wait long and you don't know how to read the soft tissue, you lose bone. And once you start losing bone, you open that roughened surface to the element, they will have a beautiful party like we had last night. And luckily, it was long before I come to give the lecture because I had a headache, especially my daughter woke up at the crack of dawn and jumping up and down. So this is what we are dealing with. I've wrote a lot of articles about it, and one was last in France. But what I did recently with our students, we've been doing an SEM study. We looked at everything been talked about into the subject. You know, you hear about somebody tells you, I'm going to rub the implant with saline. I want to rub it with chlorhexidine. No, I want to rub it with hydrogen peroxide. No, what you talking about? You rub it by citric acid or phosphoric acid. So we wanted to see, is the chemical alone does the job? And the second step was to check if the mechanical alone will do the job. Do we need to combine both of them? So the first round was for the chemical. This is the left and the right, and you can see saline didn't do anything. Chlorhexidine didn't do anything. Citric acid didn't do anything. Phosphoric, the same thing. And lastly, we went to the mechanical. When you do implantoplasty, you can see it cleans it. You can see the difference between the surface that is polished compared to the biofilm. It brings it back to the pure titanium. ProfiJet is another joke. You throw this bicarbonate, and you're going to go pray to see that the biofilm is gone. But if you look at it carefully, you can see the remnant of the biofilm all over, plus you add to it that bicarbonate. Now, we don't know if it has an effect or not, but nevertheless, you're throwing air into an open wound. We look at the titanium brush. The titanium brush cleaned, but there was some remnant. So definitely, if you do any mechanical, you're not going to reach every surface of that implant. So we wanted to combine mechanical and chemical. And I have one more experiment that I haven't had the results to share with you, is we did the water lace to see if it cleans the surfaces, and we're going to check it on SEM. So let me share with you the final case here. And you can see that tissue is soft, pus is coming out, and when we open the flap, you can see the implant. But this part of a complete roundhouse, we cannot section it, and we have to live with it. So I did the implantoplasty. I did the phosphoric acid for 1 minute, and then I treated it as a regular perio case with bone graft, cancellous cortical, and then I went to the soft tissue. I added the soft tissue to the mix, and I closed it up, and that is a case 3 years later. If you want to read more about that, I wrote 3 chapters, and they are coming right now, actually in February in Elsevier, about way of treating them and so on and so forth. So having said all of that, I like to end my lectures usually with what I call Sha'arisms, from my last name. And this is kind of a philosophy of treatment, since that subject is philosophical. You have to really have a grip on science and biology and question everything we have learned. And I love this building. Do you know that building in New York? The Flatiron building? You know that this is the first high-rise ever built in the world. First one, 1902. And in 1902 till now, it attracts everybody. Everybody comes to New York, takes pictures, including myself. I've been living in New York for 23 years. And if you look at this building from every corner, it is a superb beauty. It is fascinating because it was built on sound foundation, on beautiful architecture, with love. And that's why we should be treating our patient with love, respect, and foundation. So Steve Jobs said, you can't connect the dots looking forward. Very intense what he said. You can only connect them looking backwards. So you have to trust that the dots will somehow connect you with your future. So if we take that and we look back at our fundamentals, I leave you with those 3. Fundamentals never change. Biology always wins. And lastly, set your goal and work your way back. And on that, I want to thank the family of Dental XP for including me in their 4th symposium again, and hopefully we'll meet again.